course, we are in the State House, and it takes political prestige, it takes political awareness, and it takes political muscle to get this to the top of the political agenda. But it takes doctors, it takes physicians, it takes nurses, it takes clinicians, researchers. So it's my privilege now to introduce to you the renowned physician from Dana-Farber Cancer Institute, Harvard Medical School, Dr. Phillip Kantoff, head of solid tumors and chief medical officer.
Thank you, David. Thank you, David. I want to thank Faye for inviting me today and for the tireless work that you've done over the past decade plus in the area of prostate cancer awareness, imaging, and research. So I'm going to tackle a problem, but it sounds like I'm preaching to the converted here from everything I've heard about PSA screening. So let me see where we are here. Where's the flipper? Oh, you got it. Okay. Thank you. Stole it from me. Faye. Okay. So the question I'm going to pose here is, should we screen for prostate cancer with a PSA? You've heard a lot of advocates of it, but this all just sort of blew in our face a few months ago, as you heard from Faye and others, when the United States Preventive Task Force, which is an assembly of intelligent people, but certainly not experts in the field of prostate cancer, came out with new recommendations. I can't see the slides from here, but I'll say to you that 4 years ago, in 2008, they came up with a recommendation, which I think was reasonable, was that for men under the age of 75, that PSA was a reasonable test, we'll just say that. And for men over the age of 75, which is a surrogate for saying men with a life expectancy of less than 10 years. Now, you hear about 88-year-old men who are getting treated and screened for prostate cancer, and you say, well, where's this 75 come? 75 is looking to be, in a young age now to me, as I've been in this field for 25 years. But nonetheless, I think that screening and treatment really probably does have an upper cutoff if you consider men who have a limited life expectancy or have other comorbidities, as we say, other illnesses that might compromise their life expectancy. But what surprised a lot of us this year was, based on the data that we all were looking at, and we're students of this disease, and we've looked at the same literature as the task force has, that the task force came out with a fairly outrageous recommendation of basically stop screening with PSA. And how did they come up with that recommendation? So their recommendation was that in the U.S. population, no matter what age, no matter what race, screening is not advocated because more harm is done than good. So a lot of us have studied these recommendations, have studied the papers that were the basis for this. And I'm not going to go into this in detail because I can't see it from here, and I can't remember what's on the slide. That's one of the things of getting older. But I will tell you that there are a number of serious methodological flaws scientifically that brought the task force to this conclusion. And the community at large is really outraged about this recommendation. So what's the real problem? Well, you've heard it before. The PSA is not a perfect test. Sometimes a PSA misses a prostate cancer. Sometimes people get unnecessary biopsies. Some people who have an elevated PSA don't have prostate cancer. So it's not a perfect test, and I'll get back to the phase work in a second. So how can we reconcile the fact, I don't know what I'm saying here, the positives. How can we reconcile the positives? The positives being that unequivocally, as Faye said before, prostate cancer screening saves lives. There's absolutely no question about that. But the flip side of it is that there are men who don't need to be screened, who don't need to get biopsies, and who don't need to get treated. How do we reconcile that? And that's what the task force had to deal with, and they could not dissociate these two opposing forces. So let me walk over here if I can. Is that possible? I can't.